was to give you an overview of what I do when I see someone with brain injury, primarily when I examine them. The other is I'm going to go quickly over a few slides that I put here just for you to have them, where I wrote out some of the procedures, or I wrote out some of the summary of it, where I just wanted you to have that so it would be more complete, but it's not something I'm going to, sit and read to you. And then the other is there are a few slides that may seem a little bit simple, but I did it because I find them very helpful when I'm thinking about how to talk to other optometrists and other doctors and even to patients about how we can be helpful with brain injury. And I thought you might appreciate having them. So why should we evaluate someone after brain injury? Well, we do know that generally when you do what you might call a routine vision evaluation, that we detect how someone sees and we look for eye disease damage. But all of us who are interested in vision therapy and vision rehabilitation certainly appreciate that there's much more to it. And so we want to more assess the visual efficiency and the visual processing of information, and understand that these skills are really what are critical for reading, for computer, for daily living, for mobility. And also, we understand that when visual, or what I call the visual process, works well, then we know that we can attend better, we can sustain visual attention, and we have a better judgment of space. So I often say that the things we work on are time and space planning. And so if you want to work on it for the person themselves, that's one thing, but we also understand that vision directs action. And so if the patient is also receiving occupational therapy, physical therapy, speech language therapy, physiotherapy, cognitive therapy, any of those kinds of things, that by having optimal visual processing, they will be more successful in those therapies as well. And so I understand that many times a person will be told that they have 20/20 or 6/6 eyesight. And we know that that is such a minimal piece of what vision is all about. And one of the things that I like to say is that vision is the brain's way of touching. As soon as something is out of the reach of your arm, then you have to use vision to interact with it because you can't physically touch it. And so that's a very important thing about vision that most people don't think about. So when I talk about vision, I always say that it's a tale of two systems, or the visual process. And we talk about the focal being identification, more parvocellular, and then the ambient process, which is more the spatial orientation, localizing in space, obviously more driven by the magnocellular system. And so I like to say that it's a difference between visual acuity and visual performance. And so we know that in the focal system, it's more cone driven, it's more color vision, it's more about what is it, whereas that more peripheral, or what's sometimes called the ambient system, is more rod driven. It's more about detecting motion, and it's about where is it or where am I? And I like this drawing. This, some of you may have seen this. This comes from Dr. Dutton, who's been very involved with cerebral visual impairment. And what it's basically showing is that we have a place at the back of the eye where when light comes into the eye, it reaches the back of the eye for image processing, but that piece of it goes through the ventral stream where all the different parts of what make up an image come together. But we know that we're much more involved with this dorsal stream, which goes all the way from occipital cortex all the way to prefrontal cortex. And in the process, we are connecting with motion and attention, with motor cortex, with the frontal eye fields, and ultimately in prefrontal cortex, where they talk about executive function and working memory. And so vision plays a very big role in that. And you know that many patients have good acuity and still have difficulty in this higher level processing. And then this is just another slide of the same thing with some of those areas written out so that you'll have more of the information about them. So what are some of the things that change that are much more than just our eyesight? So one is balance, posture, our spatial orientation, and how we can just do the daily tasks that we generally don't think about very much because they are generally more automatic. So when I talk with others about the models of vision, I usually talk about the medical optical model, which is more visual acuity and eye disease, the typical kinds of things that people understand about vision. And then I say, you know, there's this more behavioral or functional model, that vision guides our movement, it directs action, it's learned, and that we can improve those skills with neuro-optometric rehabilitation or visual therapy or vision training, whatever words you use. I think the interesting thing here, and you may have it there as well, is they use the term vision rehabilitation here, but most of the time when they just use the words vision rehabilitation, they are generally talking about working with sight impairment. They're talking about low vision and not so much about the more functional side, especially when it does not involve eyesight. So one of the things here is I, have a goal to help bring those communities together more because I'm also trained somewhat in low vision, and also how do we change the wording so the public understands it better. So if you have more of an ocular visual impairment, it's actually in the eye, and that's much of what we deal with visual impairment. It's not the only thing, but it's much of it. And then in cerebral visual impairment, I do understand that the low vision community works with that also, but I think they've come to that in a newer way because I think here for many years, especially in children, the children who were in even some of the schools for the blind and some of the special programs for those with visual impairment generally had eye disease, and it was much more about their eyesight. And then I would say, maybe 20 years ago, give or take, that they noticed that there was a change in a lot of the students that they were seeing because more of them had cerebral visual impairment. And a lot of that, I think, came from the fact that there were a lot of more premature births, and we were able to save babies at a much lower birth rate. But cerebral visual impairment was certainly a consequence of that. And we had to appreciate that a lot of what looked like low vision was really very differently driven and was not the same as having a basic eyesight impairment. And so when I talk about vision and when you talk about vision, you want people to understand that when we're talking about eyesight, we're talking more about a sensory experience, and that really a bigger part of vision is the motor output side. And that when we can process well, we have better sustained attention, we have faster processing speed, and we have better comprehension and perception of things. And so some of you have probably seen this before. This is Dr. Skeffington's 4 circles of vision. And basically what he was saying is that if we look at anti-gravity and our ability to balance in the world, and then we look at centering or positioning, which some people think of as encompassing for sure convergence, and identification, which also includes accommodation, and the speech auditory process, which is that when we label things, it's another way of us interacting with them, that what comes out of that is something we call the emergent or the emergence of vision. And I find the speech auditory piece probably the hardest in some ways to understand. But one of the things that helped me appreciate it is that I often do a copy form test here where I show a child various pictures, maybe a circle, a square, a triangle, and a few others. And I ask them to draw it on a piece of paper. And what I'm looking for is their ability to draw it, how they organize it on the page. But I ask them as I show them each picture, the name of it before I start the test. And I often find that if they cannot name it, they cannot draw it. Even though they see it, if they don't have a name for it, they cannot draw it. And so that's where I noticed this speech auditory piece is such a big piece of this emergence of vision. So what are the things that patients come in with after a brain injury? ABI is acquired brain injury. Some people say TBI for traumatic brain injury, but not all of them are traumatic. But in any case, the kinds of things that we see are commonly blurry vision or double vision, a lot of headaches. Many complain about having difficulty reading, and sometimes they complain about dizziness or nausea. Those are not the only symptoms, but these are very common ones. The other thing is that we will observe, or they perhaps have been diagnosed with, sometimes attention deficit. Some of them will come in with what's now being called unilateral spatial inattention, what was called visual neglect. Sometimes it's now called spatial neglect. And many come in with light sensitivity and photosensitivity. Some have a low blink rate, so they may have dry eye. And they often will have some kind of spatial disorientation. They have difficulty with direction or distance or making their way easily through space. Some of the other things that we observe, or again, they may report, are double vision again, the reading difficulty. Headaches are big and they're not all visual, but they are a big piece. Light sensitivity, this dizziness or spatial disorientation, which can include their depth judgment as well. And there's an interesting one that I hear a lot, which is, I see it, but it's just not clear. And I think that that, again, is probably a localization piece, more magnocellularly driven. And I think over time, we may find that it's other pieces as well. And so I use this slide, and you're welcome to steal it, which to show that if someone has double vision, especially a child, they may not report it. And the reason they won't report it is, one, they may not realize that you should not see that way. And the other is that if the print is large, like it typically is in children's books, you can still read this. It may not be all that comfortable, but you can make it out. But when that exact same print, and I offset these the exact same way, you can see that when it gets very small, it's much more difficult to read, so that a child especially may do well when the print is larger. Even an adult, if they're just getting back to reading, maybe reading some large print or finding they're just reading the headlines in a newspaper. And then when they start to try to read the smaller print, it becomes more difficult. So let's talk about the visual skills. You all know this, but I have it here just for the sake of completion, that we want to look at fixation, pursuits, and saccades in terms of oculomotor. In terms of accommodation, we want to know not only how much accommodation someone can call up, but what's the facility of that accommodation? If they have to look back and forth between things, how quickly can they shift their accommodation? And then in terms of binocular vision, not only obviously do we want to know they're using the two eyes together, but what's the stamina of that? What's the stability of that? Because if someone has very weak binocular vision, it may not take much before they cannot sustain using it, and they may have difficulty, for example, later in the day and not so much earlier in the day. Or they may have more difficulty with certain tasks and not others. Now, also, we have to think about higher level processing of information, what we sometimes call visual perception. I think it's really important that we look at the visual field, but not from a disease standpoint, but from the standpoint of how well are we using that peripheral awareness and peripheral information. And then all of these things, certainly many of them anyway, play a role in balance and posture, though there can be vestibular deficits as well as the visual system and the vestibular system not cross-talking with each other very well. And so when we look at fixations, you all know that it's the ability to hold the eye steady on a target, but some of the things we may see is poor eye contact, or lack of focus. And when I say lack of focus, I don't mean just clarity, but the person's attention on things. And when we're looking at pursuits, how do we track or follow both close, both far, both indoors and outdoors? Although I feel like we use pursuit eye movements much, much less than we do fixation and especially saccadic eye movements. So for saccades, we understand that you can lose your place or skip lines when you're reading. You may read the wrong part of a word, and any type of following, whether it's during sports, whether it's maybe when you're playing a board game or a card game. It can be when you have to look between things outdoors, trying to cross a street. It's certainly something that we use quite a lot. And so what are some of the functional changes that are associated with brain injury? And we do know that when we make diagnoses, we may be talking about an oculomotor dysfunction. We may be talking about convergence insufficiency. We may be talking about the instability of accommodation, the loss of stereopsis or depth perception. It could be a visual field loss, and that could be from pathology or more functional. A patient may have visual spatial neglect, or they may all of a sudden demonstrate strabismus. We do know that they can have issues with balance and posture, and Dr. Padula here in the US has talked about visual midline shift syndrome. I do think that it's a deficit in egocentric localization, but in any case, it's a term that's been used a lot, and so we can continue to use it because people know it. And then a lot of patients have difficulty with visual memory, and often with higher level visual processing, and often also visual motor integration. And they can have a decreased blink rate, especially if they've been in a coma for any period of time. And obviously, sometimes they do have visual acuity issues as well. So Dr. Padula, a number of years ago, termed what he called the post-trauma vision syndrome. And the characteristics of that are exotropia or high exophoria, convergence insufficiency, accommodative insufficiency, spatial disorientation, and unstable peripheral vision or unstable use of that ambient visual system. In terms of the symptoms, some patients will talk about diplopia or double vision. Often they have poor concentration and attention. They may actually say that objects appear to move. For example, words moving on a page, or things don't seem stable in their environment. And they talk generally about asthenopia or eye strain. Now we're going to go on to another section here. So if we're doing a vision evaluation, what are the things that we want to do? And so one is that we want to do a comprehensive case history. I think that it's incredibly important, and you'll see later I have some slides with the typical kinds of things we ask in our history. Obviously, we want to look at visual acuity. And when I say be careful about the type of acuity test used, I've had over the years, maybe half a dozen patients that I was told before they came in that they were legally blind, meaning they couldn't see more than the large E on a typical chart. And when they came in, they had better visual acuity than I do. And the reason is because someone was trying to get them to read letters and they had some kind of aphasia. They had some kind of a speech language issue in which they could not come up with the names of the letters. And when I tested them by either being able to match when using letters, or I used pictures, also by matching, sometimes I even just used preferential looking, they had excellent visual acuity. The other thing that I do notice is that distance visual acuity is looked at, but no one thinks about near visual acuity, because they think that the person may not be reading very much, especially if they have a very significant injury. But I used to work a lot, and still do, with a lot of special needs patients. And the first thing I say to someone is, if they're 35 or older and they're looking at near, it doesn't matter if they're trying to read, they may want to see the food on their plate. And they have to think about the fact that someone may need a near type of lens, even if they're not doing a lot of looking at very small things up close. And then, of course, we want to know what we need to do in terms of their eyeglasses or contact lenses. And we'll talk about some research that was done along those lines. And obviously, an eye health assessment. But you know that when you look at these things, you think, well, that's just the start of an evaluation. That's not the end of an evaluation. But for many doctors seeing patients and seeing these types of patients, that's where they stop. And we know that's not enough. So when it comes to refractive status, in one study, 50% of the patients required a prescription. Some of those needed eyeglasses for the first time. Some needed a replacement for lost eyeglasses, and some needed a change in prescription. I would say that I don't see patients who have lost eyeglasses all that much. Although sometimes that happens because they've been in a rehab facility or somewhere for a period of time where they do get misplaced, or someone doesn't even know they're supposed to have them. But I do see needing eyeglasses for the first time, and I do see certainly needing a change in prescription, or if not the prescription itself, the way that we facilitate that prescription. For example, multifocal lenses, progressive multifocal lenses, often make symptoms worse. And so for some patients, we have to do either a standard bifocal if they can use it, or we have them have a different pair of eyeglasses for distance and a different pair for near. So in our evaluation, obviously we want to look at pursuits. We want to look at saccades, and we can do that generally or with some type of normed test. We often want to very carefully look for strabismus, and more often we will see exotropia than esotropia. And I just want you to remember that when we see a patient who's suppressing, that's not a passive process. Their brain is actively working to turn off that vision. And so there's a lot of effort and energy going into that. And that when patients see double, you may want to ask them at first, or when they're in your office, if you cover one eye, does it go away or not? Because I do see patients who present with monocular diplopia. And what they tend to do here in a lot of rehab settings is that if someone is seeing double, they put a dark patch on one eye. That is probably one of the worst things we can do for a patient. And that's because if you put a dark patch on one eye, First of all, you're taking away all the peripheral vision on that side. Second of all, if their brain is trying to bring the images from the two eyes together, what will happen is that periodically while they're looking at something, they will have these short intermittent periods of darkness. And so if I have to use anything at all, I try to use the smallest occlusion possible. It could be binasal occlusion. It could be some type of spot patching where it just covers part of the lens. If I have to cover the whole lens, I will use some type of material that reduces the image itself, but allows light to come in. We know that just because you look like you can converge or diverge your eyes, that the stamina for doing that is not always very good. And so I take a 12 base out, 3 base in prism that I have. It's like 2 prisms together. And I go back and forth between them in front of the one eye of the patient while they're looking at a target. And I can look at how well they can hold both the binocularity and clarity of the target. In terms of accommodation, I want to look at how they can shift from distance to near and also how well they can hold it at near. But that shift really tends to be more of the issue for a lot of patients. And I can test that with a ±2 flipper. I also sometimes just put some letters up on the wall and I have the patient looking at some reading material and just ask them to look back and forth and see how stable it stays for them. In terms of depth perception, we know that we want to measure stereopsis, which is 3rd degree stereo. But I will tell you that I also like to talk about what I call depth judgment, because even patients who can pass a passive stereo test, one that they are doing while they're sitting quietly in a chair, is not the same as how quickly they can make those spatial judgments when they're moving through space. And so even if that's not something we have a particular measure for, we should be aware that just because someone does well on a stereo test doesn't mean they don't have difficulty in real space when they are moving, when things are moving, or when all of it is happening very quickly. In terms of visual field, we do understand that it can affect mobility and even attention to things. If you have functionally a very small visual field, a small area in which you can process visual information, then it will affect your attention, your concentration, even your ability to understand the information, because it would be like trying to read a word one letter at a time versus seeing the whole word. And we do understand that we can test visual field by confrontation, by automated perimetry, by kinetic perimetry, which is more sensitive and much more useful when we're looking at functional field. For unilateral spatial inattention or neglect, there are 2 tests, one called line bisection and one letter cancellation. I don't use them very often because I've usually figured out that they have that condition without doing those tests, but it is one way to look at how they are perhaps attending only to 1/2 of the visual field. And then sometimes you want to think about, well, what does it look like when they are just performing daily activities? Because many of these tests are very passive in that the patient isn't moving. It's quiet. It's easy for them perhaps to concentrate on it. But what happens when they have to have an awareness of everything around them as they're also moving through space and those things are moving? So I think that's a way of assessing it more informally, but can be very, very helpful. And if not from the patient themselves, a lot of that information can come from those close to them. So here's someone doing a more functional visual field. They are looking at the center of the target where someone is pointing to it at the top. And at the bottom, you can see a field chart. The patient would be looking directly at the center, and someone is bringing in small targets from non-seeing to seeing for them to let them know when they first notice motion, Then when it stops, they can tell that it's round and circular. And then we also use color to look at color visual fields. All of that is a lecture for another day, but it is something that can be very informative. In terms of visual midline shift syndrome, what are we asking the patient to do? Well, the patient is looking straight ahead at you initially, and then you may take a wand. I often use what's called a wolf wand. It's just a stick with a small gold ball or a silver ball on the top. And I put it off to the side and I ask the patient to look at it. And then as I bring it across their visual field, similar to doing a pursuit eye movement, I ask them to tell me to stop when I'm directly in front of their nose. And what you will sometimes see is that the patient will stop you when they're more in front of one eye. And then you can appreciate that perhaps their sense of center is not where it should be. And so this is just kind of a drawing of it, that will that patient be leaning away from the affected side and may say that things look tilted or that things appear to shift or move. Or when you have someone who does have some hemiaplesia, even though they can't use one side of the body very well, we do find then there often is this midline shift. And when we use lenses and prisms, especially prisms, to shift that and move that so that they feel more centered, you will often see that even their mobility then improves greatly. So these are the slides I'm not going to read to you, but I did put here the questions we ask every patient before they come in. And if they are not able to answer it themselves, we try to get someone to work with them to try to answer it as best possible. And you'll know on the right, it should say above the word injury, it says prior to, but you can see that on the slide, it kind of jumped over to the left there. It should be above the word injury. The reason we ask if they experience any of this prior to injury is, at least here, very often if there's been a certain type of accident. Can you mute please? Hey guys, mute. Thank you. What we do notice here is that if someone has fallen on a sidewalk somewhere, can you guys mute, please? Okay, we'll try to talk around it here. So what we do ask here is if it's prior to the injury. Okay, they're muted now. Because here, if, for example, I'm in a car accident and someone has hit my car, if I am injured in a certain way, sometimes I will need to bring a lawsuit against that person so that they help to pay for my injuries or my disabilities. And so because often here, these things can turn into lawsuits, I want to be able to say that if I'm called into court and have to testify about the patient's condition, to say whether it was there beforehand or not. That doesn't mean it wasn't made worse by the injury. I had one patient that I had to testify for that had strabismus. And I said, look, they had strabismus their whole life, but they had a good job. They had good ratings at their job. They had no difficulty doing most of their daily activities that they needed to do. They were able to drive a car. And afterward, they couldn't do most of those things. So clearly, even though the strabismus was already there, something was made much worse by the injury. But that's just something we feel here, or at least I feel here, I need to ask. And here are other questions that we do ask. Again, I'm not going to read them, but you can see the kinds of things that I try to understand. One, because it's helpful not to spend a lot of time questioning the patient when they come in, because they do fatigue quickly. Sometimes they can't answer these questions themselves. Occasionally, what I'll do is just re-ask. I'll ask another time some of the things that they said yes to, just to see if it's consistent, or if they were not the one answering the question, how do they answer it when I ask it directly of them? But mostly I want this for ease of use, and also so that I can delve right into the exam and not spend a lot of time asking the history questions. And here are some others that we ask. And again, you're free to use any of this that you would like. So what's the difference from a low vision rehabilitation exam, or when we say vision rehabilitation, what's the difference between looking at it more neuro-optometrically versus low vision? I think that the difference is that many of our patients have adequate eyesight. Even if they wear eyeglasses, at least with the eyeglasses, they can see clearly enough. But then when they have to integrate visual and kinesthetic and proprioceptive and vestibular input, they have a lot of difficulty. And so they have issues more with walking, reading, writing, driving. It doesn't mean that with low vision you don't have issues with those things, but these are patients where the expectation is that they should be able to do most of those things because they see relatively clearly. And I also think that addressing these kinds of things from this perspective is relatively newer, whereas the opportunity to help someone with a sight impairment has certainly been around and talked about for much, much longer. So I think people are more familiar with that. But in both cases, we're looking at visual function, but maybe in a slightly different way, or in some cases, it's a combination of both. And so now, just getting into this next section, what am I going to do when I want to do a vision screening? And the reason I call it a screening here is that these are some of the basic tests that I would do as part of my evaluation, but also you could teach others to do some of these basic tests, perhaps in a rehab facility, in a hospital, somewhere where the patient may not yet get to see you, but you want them to have a sense that they should refer the patient to you. So if it's occupational therapy, primarily here, it could be physiotherapy, even speech language. I mean, I got called into a hospital once, a rehabilitation hospital, to see an older gentleman because the speech language therapist couldn't understand why he was having so much difficulty with the things that she was trying to do with him. And when I walked into the room, I saw a man who was probably maybe about 70 years of age. And the first thing I said to him is, "Do you wear eyeglasses at all?" And he said, "Well, I have these glasses for reading. I don't always need them, but I have them." But they were not there at the hospital. And sure enough, when I tested him, he had difficulty with even relatively larger print. And as soon as I put on some near-point lenses, he could read perfectly. So this speech language therapist was spending time with this patient, trying to do things that were not easy for the patient, all for the lack of a pair of, +1 or +2 lenses. The speech language therapist never thought to ask about eyeglasses. The patient never thought to mention it. And I got called in to basically prescribe what here you could buy in a drugstore. And so it's interesting that sometimes they just don't think about the bigger picture, no more than maybe we miss things sometimes. But we do want to look at stereopsis. We do want to often use the Worth 4-dot test. And if you're not familiar with it, I have a picture coming up. What I like to look for is not just suppression, but instability. Especially at near, I tend to hold the flashlight of the Worth 4-dot test in front of the patient for maybe 30 seconds to a minute and see if, other than the bottom dot changing color, which is normal, I do try to ask them if anything seems to change. Do any of the dots go on and off? Do they move left or right? Do they move up or down? And you'd be amazed at how sometimes you stand there and within the space of even a minute, it changes quite a bit. And so these are the typical stereo tests that we use. The one on the right here has a fly that pops out of the page, and then it has these small circles. And for younger children, it has some animals here. And then the one on the left is random dot stereo. And there are larger pictures in the squares on the right, a smaller sort of circle that pops out in these diamonds on the left. And then there are some smaller versions of these large pictures also here on the left for younger patients. I often with the stereo fly, what I'm interested in is not only do they see it coming off the page, but if I ask them to reach out where it looks like it is in space, how do they localize it? And then I want to look for the higher level random stereo. In terms of the Worth 4-dot test, it's just these lenses used, this flashlight with the 4 dots, used with red-green glasses, and then here are some of the responses. This would be a normal response where the bottom dot would look either red or green, or some patients tell me it looks yellow because it's a combination of red and green. If they are suppressing the left eye wearing the green lens, they will only see the right eye. Here, they're only seeing the left eye. Here, they have, if this is the patient's view, and they are seeing the right eye image on their left, that's cross diplopia or an exo response. And this would be uncrossed diplopia or an ESO response. So how do we want to look at visual tracking and locating? How do we want to look at their convergence ability, since many have convergence insufficiency, and their eye teaming, both in terms of its accuracy, stamina, and stability? So I did write out here the Nsuko Maples oculomotor test. I don't need to tell you how to necessarily do pursuits and saccades, but if you want to standardize it a little bit more, this is a way to do it. I did the same thing here for you for saccades. But what I did do is, if you want a very simple scoring system, you can use this. This is what I use, which is from the Southern California College of Optometry, which now has a new name. It's not called that anymore. I think it's called Ketchum University. But anyway, it's a system of 1 to 4. And you can see if it's smooth and accurate, if they have more than 1 fixation loss, more than 2 fixation losses, or any uncontrolled head movement. And in terms of saccadic ability, are they undershooting the target? In other words, they kind of stop just before the target and then maybe move their eyes over to it. Do they go a little past it? Can they not do it? Or do they do it only with basically head movement? And also, how do they kind of initiate it? When you say, I want you to start looking back and forth between these 2 targets, do they start right away, or do they kind of wait and have to almost think about it before they can initiate it? And so when we're assessing convergence, we want to do a near point of convergence. We know it can be quantitative, but we also want to look at it qualitatively. I have patients where, they're kind of pushing their head back into the headrest because they want to get away from the target. Is it comfortable for them? Are they trying to kind of close one eye, or are they squinting, or you could just see that they're not comfortable doing it, even if they can manage the task. So I think both of those things are important. You know how to do the test, but these are the norms that I have been using. And it's interesting because I just had a conversation with a company this week that's trying to add a near point of convergence test to an app that they have that already acts like a pupillometer. And they were saying, well, what should the norms be? Because they were hearing different things from different people. I'm comfortable with saying that it should be no greater than 3 inches or 8 centimeters from that should say bridge of the nose, not bride of the nose. Sorry, I didn't catch that one. And I'm also interested in the recovery, because I do notice that many times when you read about near point of convergence, they talk about where the break point is, but they don't talk about the recovery. In fact, there was an article just published this week that talks about convergence near point early in the day versus late in the day. And all they mention is the break point. They do not talk about the recovery at all. And they do say there is a difference between earlier in the day and later in the day, and that maybe if we're assessing patients, we should be taking that into account. My feeling is if it's worse later in the day, then they don't have the stamina and stability of it that they should have. So I don't want to change my my norms because I'm doing it at a different time of the day. I want to appreciate that for that patient, it's not the same as at the end of the day as it is at the beginning of the day. But I haven't fully read the article yet because I just found it last night, and it'll be interesting to see what they have to say. But the other is to repeat it 3 times, because I have had many patients where you do it once and they do well, and that each time you do it, they do a little bit worse and a little bit worse. And even in as little as 3 times, you can see the breakdown. So there's just someone doing a Brock string showing convergence. And interestingly, that gentleman is 101 years old doing vision therapy. And on the right, you can also see someone converging. So this again is more for you. It is if you want to create a vision screening assessment form, maybe something that you give to other professionals to use. This is just something that I've used, and I'm just going to run through it here. We put all these different things that they can fill in, and then ask them to do some of the screening, like the pursuits and saccades, and maybe some type of near point of convergence, possibly stereo, and then maybe a short confrontation visual field. And then it's mainly to be able to say, look, we need to refer this patient either for the Neuro-Optometric piece, low vision. Do they need to see some other type of physician or therapist, or are things now pretty good? We know these are the important factors: the fixation, the tracking, the locating. I think when we talk about oculomotor, we need just as much to talk about fixation as we do pursuits and saccades. And I think we need to understand that it is intimately connected with our ability to locate a target. So it's not just convergence when you need to locate a target, but that you need to also be able to use your oculomotor system, because in my view, the oculomotor system is driving those other skills. I think it drives convergence and accommodation. The other is a lot of people talk about the clarity of things. And I always say the driver is really the convergence. You have to locate it before your brain is going to know how to accommodate and make it clear. And so if all we're paying attention to is how clear can we make a target for the patient, perhaps with eyeglasses, we're kind of missing the point. And then the visual vestibular system. These skills lead to sustained visual attention over time and faster processing speed. And those are 2 pieces that I think are very important that are continually missed. Also, what about cognitive load? If I do a basic pursuit movement, let's say I just take the tip of my pen and I say to you, follow it. You may not have any trouble doing that. But now, while I'm having you do that, I might ask you some simple math problems, or I might ask you to spell some words that I know you know. All of a sudden, in many patients, you will see that they can't do the following and the cognitive task at the same time. So that basic pursuit skill is not going to serve them well in the real world, because they cannot do it at such an automatic level that they can now do these other tasks. When these visual skills work well, they kind of sit in the background. I always say to patients, it's like the operating system of a computer. If you're using Windows to run your computer, if it's working well, you have no idea that it's working well, other than that you can do the things on your computer that you're trying to do, whether it's word processing or getting on the internet or moving between different tasks. But if that system is acting up, then you see that you can't do the things that you normally could do very easily. But it doesn't show itself unless it's not working well. So what are the kinds of things we can do for treatment? Well, we certainly can do prescription eyewear to improve sight. And I do think there is great value in a good refraction. I can't tell you how often I have been able to help patients by doing a very careful, very controlled refraction and looking at both distance and near. I think that at least here in the US, because there's been so much more emphasis on our ability to diagnose and treat eye disease, we've kind of left the aspect of refraction to a lesser place than we used to. And I think it is incredibly important. I also think that we have to think about prescribing lenses, not just for eyesight, but how do lenses help us focus? How do they help us coordinate our eyes? How do they provide a better base for that interaction between the focal system and the ambient system? We do know that often color filters or tints are helpful for light sensitivity. We know that with certain kinds of reading disabilities, certain colors on the page do seem to help. We know that prism lenses are not only for double vision, but that we can use them to help someone orient better in space and therefore have an effect on their balance and their posture. We do know that rather than fully covering one eye, we can use some type of selective occlusion like binasal occlusion or spot patching for strabismus and double vision. And then we do have the ability to do a program of vision rehabilitation, which more than just talking about helping visual impairment means that we're helping to remediate the functional vision deficits. And on the side of what falls both, I think, into low vision and neuro-optometric rehab is visual field expanding devices, which may be a prism expansion system or yoked prisms, or vision therapy for more and better fixation and scanning. And then don't forget about optical and non-optical aids, especially the non-optical side. You know, it's very easy to help patients by just having them use, for example, an L-shaped marker. If you have someone with a left hemianopsia, for example, if you have them take a sheet of paper that you've cut into the shape of an L, and they have it at the very edge of the print on the left side, with the bottom of the L being longer and going partway across the page, they will be able to notice the bottom of that L as they come back to that left side and be able to move it down one line and then be able to know when they hit the vertical part of the L that they're at the beginning of the line. I have heard that sometimes they have patients turn a book 90 degrees and try to read that way. I find that a challenge for many patients, but it's a thought. And also to very much watch the sizing and the spacing of print. So for example, patients that even have certain kinds of reading disabilities, if we make the print a little bit larger, not huge, but a little larger, like maybe from 12-point type to 14-point type, and then we make the space between each line of print, which normally is almost about the same size as the point size of the print. So for example, if you have 12-point print, that spacing is usually something like 12.1 points. So it's about the size of the letters. But if I change that spacing between the lines to be 1.5 times the point size of the font, so if the font is 12 point, and now I make that spacing 18 point, many patients will now be able to read significantly better. The other is I've had patients where just making the print more into columns rather than going across a full page makes a big difference. I had a young woman I was working with Down syndrome, and she could read pretty well, but she was having difficulty skipping lines and not being able to keep her place easily with reading. And we did work on a lot of oculomotor skill, but it never really got a lot better. And so I said to her, Mom, you know, I don't understand why they're not giving her material that doesn't go so far from left to right. Well, it's not, you know, more looking like a column of print. And so she went back to the school, and they made some wide margins on the page and reprinted some of the material. And she started to read 20 words per minute faster, which is huge. The other is to look at lighting. One is sometimes patients use too much lighting and create glare on the page. And the other is the color of the lighting. And by that, I mean lighting has a color temperature. So incandescent lighting tends to be more yellow, and what we call high Kelvin or high color temperature lighting tends to be more white, and often patients can read better with the whiter light. And then, of course, we have to monitor and manage any eye disease. And as we're kind of finishing up here, you want to think about just the position of the person and the position of the material. You know, if we are not well supported in our bodies, then we cannot move our eyes as easily. So we cannot use vision well if we don't have a good base of support. So when I have a child here or an adult here that has issues with their posture or balance, I make sure their feet are well supported, that they're in a chair that supports them well, that the material they're looking at is propped up at an angle so they can see it more easily. If they have head control issues, then I work with that. And so all of those things go a long way toward helping the person. Also, contrast can be a big issue for patients who have had brain injury. So think about paper with darker lines. Think about the kind of pencil or pen they may be writing with. If it writes a little bit thicker or a little bit darker, it may be easier for them. If certain text is important, it may be helpful to have it in a certain color or to be highlighted. There actually are some software programs and even some apps where as you read along the print or it reads it to you, there is a yellow highlight that highlights the text that it's reading. I don't like typoscopes very much because they generally are a window, but the rest of the card is black. What I prefer is that the rest of the card be kind of a very light gray so that it does sort of block the other print, but they know that it's there. The other thing is we tend to use it where we keep the window at the top and have everything below it blacked out. I think we should flip it over and use it the other way around, because I think what's important is that the person know where the next line of print is and be able to pay less attention to what they've already read. If it's still bothersome to them, then I would have a sheet that is a light gray with the window across the middle, so there is gray above and below the window. But I think that typoscopes don't make any sense to me that you'd be blocking where the patient is going to go next. Lighting can be important, and we just talked about that. And thank you, but I will show you just a couple of other slides that are in the handout, which is that today I've spent time just showing patients many of the accessibility options that are on their smartphone that can be helpful to them. Most people don't know those things are there, and we know that the smartphone manufacturers are continuously coming out with new options that help all of us, but especially these patients. And again, these are the things that we can do, which you know, but I just summarize them together. And these are some websites that can be helpful for additional information. So I'm open for questions. I will end this and see if I can get to my chat.
Well, thank you so much, doctor, for your wonderful session. And I'm looking for the question.
Yeah, my chat's not showing up here for some reason. So,
Okay.
oh wait, I know. Wait, I can do it. If I stop the share, I think there now I can get to it better. Yeah, so far there aren't anything. There's nothing here except hello, and I say hello to everyone. And, but really, please feel free to ask questions. It was a lot of information, but I also wrote a lot of it out so that you would have it in the handout so that you can refer to it in the future. No questions? Getting to be late?
Yeah, we have to wait. Actually, people might have a typing.
Yeah, no, I know. I'm waiting a few seconds, but you know, certainly at some point, you know, we've talked about maybe having a session where we demonstrate some of these tests for people that aren't familiar with them. And many of these topics can be expanded. We could, you know, we could spend 2 days just talking about the vestibular system, or at least a full day. And then also appreciating, you know, some of the other therapies, certainly talking about color and using tints and how we use color, the effect of color, some of which we touched upon at the last lecture, but again, more in depth. So there's always more to learn, but I think you have to start with the basics and really just think about the tests that you normally do, but being a good observer. What do I call the visual field testing in my slide? That test was essentially a near tangent screen type of device. That particular one has a small, about a little bit bigger than a size of paper, that has the target on it, just like you'd see on a tangent screen. And it had a light above it so that the paper was illuminated all the way around. There are some devices like that. They are primarily for doing a near visual field, and it's a kinetic field, and it's done with some wands that have a white target or a red target, a green target, a blue target. And it can be used with anyone, but we find it especially helpful when, again, we really want to look at the functional field, because many of these patients will have done okay with a standard automated field. What is the time duration between trauma and starting vision assessment and therapy? I think vision assessment can start right away, especially if a patient has an issue like double vision. It doesn't mean that some of that won't resolve over time. But, you know, I have some rehab hospitals here, and there's a doctor here who comes more from the low vision community, who tells them that they shouldn't get prisms in the beginning because then their eyes won't heal or their visual system won't heal properly. He's not very big on giving lenses initially. And what I like to say to them is, you know, if I hurt my leg and you know that in 6 months it will be better and I will be able to walk, does that mean you don't give me a wheelchair or a cane or a walker or something along the way that meets me where I am at that moment in time? So I feel the same way about the visual system. If someone has double vision, even if I think it's going to resolve in 6 months with no therapy at all, can I let a patient walk around for 6 months with double vision? That's what they tend to do. And I just think that it starts at the beginning. I often see patients much later after the injury, sometimes years later, because this aspect of vision is not well known and well understood. But some colleagues of mine, and I do this too, is we go into hospitals and often see patients in the first few weeks after an injury. So I think it just depends on what the patient is struggling with. I think that it should happen very early on. And again, what you do at 3 weeks post-injury might be different than 3 months or 3 years, but it doesn't mean that you aren't supporting them all along the way. How to know from kinetic perimetry that it's affected from their brain injury? Well, you could have someone, if I understand the question, Eileen, that could have a constricted field, not from the injury. We certainly measure it in patients who who apparently have no history of brain injury. And I say it that way because something reduces that field, although we do know that even emotionally we can find it. It doesn't have to be a direct brain injury, but it can be what I'd call more of a biochemical injury. But I do think that it doesn't matter if it's from that brain injury directly, if it's been exacerbated by the brain injury, you still want to work on expanding that field. And how do we expand it? It can be prisms, it can be syntonic phototherapy, it can be a combination of either of those. I think those are good questions. I think that if you don't have any particular instrument to do the field, what I often do, especially when I have someone just sitting in the chair and I'm not sure how well they're going to do with doing a more formal type of kinetic field, is I just take a wand with a small target, very small target on the top, and I bring it in from the side while they're looking at me, and I just bring it in from the other side while they're looking at me, and I don't even necessarily do top and bottom. And often they'll tell me they're not noticing it or noticing the color of it until it's practically in front of their face, or in front of their nose, I should say. And so I know that there's an issue there. You can just take a sheet of paper and put it in landscape mode, put it in front of them, hold it at a set distance. I even have a little holder where I can put it and set it at a set distance, and bring a small, I have like a little pin with a little black ball on the top. And I just bring that in from the side until they tell me that they can notice it and notice its shape. Again, it's not quite as formal, but because I know the distance of the chart and I can mark where they notice it in different quadrants, I can then calculate how many degrees that field is constricted. And that's without trying to map the blind spot or anything else. So it's an easy way to do it if you don't have any formal tools, or the patient may not be able to use those formal tools. Any other questions? I know it's getting a little bit late for you guys, but I want to thank you, and we will certainly meet again, I'm sure. And I know there's been a lot of interest in syntonic phototherapy, and we're going to talk about how to bring that to you. And if you have questions about any of these other things, feel free to contact me. I can put my email in the chat. And I hope that you will do more of this and extend more of this to both your own colleagues, as well as having an opportunity to do some talking about it to other professionals who work with patients with brain injury, because here we tend to be the last person they see, sometimes years after their injury. And I would like to see that situation change.
Okay, doctor, thank you so much for such a wonderful session, and we are very kind for your all these lectures. And if there is any words more than thank you, I obviously use for you.
Well, thank you. I enjoy this. I enjoy it. And I know that all of you are excellent students, and you're going to take this and really use it. And that kind of warms my heart. I really like it, that. That's why I enjoy doing this.
Your doctor, and also we love to go through the syntonic if it is possible. And we also love to go through the.
You and I will talk about that and figure out a way that we can go forward with that. I'm kind of working with the College of Syntonic Optometry right now to see how we can get more of you to be members in a way that's affordable, and then have access to more information and materials as well. So we should have that in the next few weeks.
Thank you so much, doctor. And we also love to have a live session or any future, any workshop, if it is possible to come here you in Nepal. And we
I'd love to come. I'd love to come. Yeah. When I was supposed to go to India in March, they locked down the visas the day before I was supposed to leave, or I would probably still be stuck there, and I'd be visiting you too. COVID will get under control one of these days soon. And when it does, I'll be sure to be traveling again.
If you were there, if you are in here, and we'll be stalk you. We'll not
Yeah, I'll have
easily
to get in good
go from the
shape though
Nepal.
for all those hills there. I'll have to get in good shape. Yeah.
Sure, doctor. Sure, doctor. Once again, thank you so much.
All right.
And
And you and I can talk at another time about all this.
yes, doctor, I'll make you call very soon.
Yep. Sounds like a good plan. And thank you everyone for hanging in there.